Thank you very much. It's a pleasure for me to be here speaking with you today and to represent the SLIC group, the Systemic Lupus International Collaborating Clinics, and I just happen to be their spokesperson today. I have no disclosures. As a background, patients with systemic lupus develop premature atherosclerosis, as we've heard, and in established cohorts, a cross-sectional prevalence usually runs somewhere between 10 and 15%. The average time to develop an atherosclerotic vascular event is somewhere around 7.5 years. The SLIC group, you can see represented here before you, represents 31 centers from 12 countries in North America, Europe, and Asia, and therefore represents a true multinational cohort. We're real people. And you can see in front of you here, there are Canadians, UK, British, Americans, Swedes, Danes, Spanish, etc. So, in fact, we are a multicentre cohort. One of the goals of SLIC was to establish an inception cohort of lupus patients according to a standardized protocol, and these have been followed between 2000 and 2012 for this study, to study the risk factors for atherosclerosis. Our data retrieval protocol includes both clinical and laboratory features of lupus and the coronary artery disease risk factors, and it also includes the atherosclerotic outcomes based on a glossary of established definitions. So the objective of this study was to examine factors at inception. Now I stress that. When you see the patient as a new patient with lupus coming into your cohort, newly diagnosed, to establish predictive factors for atherosclerotic vascular disease over the next 12 years of follow-up in our cohort. Patients are included in our cohort if they're within 15 months of diagnosis and they have 4 or more of the ACR criteria. This is before we had our own criteria. At each yearly visit, we collect demographic and cardiovascular risk factors, and the vascular events are described and attributed on a specialized form. So, the inclusion criteria were the patients who were entered in our cohort. We excluded patients who only had one assessment, and therefore we didn't have long-term follow-up. And we excluded patients who had events due to non-atherosclerotic factors such as active lupus or obvious thrombosis. The events that we recorded were myocardial infarction, angina, congestive failure, intermittent claudication, stroke due to atherosclerosis, and transient ischemic attacks. The diagnosis of the event was confirmed using standard clinical criteria and diagnostic tests where appropriate. The big issue is whether we could attribute these events to atherosclerosis, and this was rigorously pursued. So to be attributed to atherosclerosis, the lupus disease had to be inactive at the time of the event. There had to be the presence of typical atherosclerotic changes on imaging or at pathology, and there could be evidence of atherosclerotic involvement elsewhere. Statistically, we did the descriptive statistics and a Cox proportional hazard model, which I'll show you. And then, in order to clarify some of our dilemma, we did a nested case control, which I'll show you in a few moments. So as results, we had 1,400 patients in this analysis. 90% were female. Their mean age was 35 years. And you can see we had a spread of ethnicities, 51% Caucasian, 16 Black, 17 Asian, 12% Hispanic, and 4 others. 31 patients had 41 atherosclerotic vascular events after enrollment. That is in this 10-year period. Remember, newly diagnosed, seen for the first time, over 10 years, 41 developed an atherosclerotic event. The mean range of time to the atherosclerotic event or to the last clinic follow-up if they didn't have an event was about 5 years. So the events were, as you can see, myocardial infarction in 5, angina in 4, congestive failure in 2, peripheral vascular disease, stroke, transient ischemic attack, and pacemaker insertion. One patient had both angina and the myocardial infarction. So what were the risk factors that were present at enrollment? And like you've already seen in the first few presentations, at enrollment, patients with lupus tend to have a number of the classic risk factors present, so that they tend to be those patients who later developed an event were older, more often male, more often had diabetes, had a higher Framingham risk score, were more often smokers, hypertension, hypertension, not hypercholesterolemia, not increased LDL. This is at inception, and had an increased serum creatinine. This is exactly what you would expect, and you could say, there, I've got it. I knew that this is a disease caused by the risk factors for atherosclerosis. If you look, though, at a time-dependent analysis in a univariate fashion over the 10 years, not at inception, but in a time-dependent analysis over 10 years, again, you say, again you say, look, exactly what we expected. Older age, interesting here that Caucasian came up as more prevalent, male still, smoker, obesity, hypertension, but not hypercholesterolemia. So this is in a univariate analysis. But then, when we did a multivariate analysis, the only factors which remained were age and male gender. Okay? So this is in the first 10 years of illness, only age and male gender were significantly associated. So what does that mean? Here were all these factors, and all we could come up with was 2 factors in a multivariate analysis. So were the results due to the small number of atherosclerotic vascular events? Remember, it's still early. Our first studies showed that it takes at least 8 years to develop an atherosclerotic event, and this was only 10 years, so it might have been too early. And so we didn't have enough events, and therefore there wasn't enough power for more than 2 variables in the model, age and gender. Was this due to multicollinearity between age and gender and other risk factors? That is, older men have more risk factors, so they predominated. And in the short term, atherosclerotic events were more likely to occur in older males. So in order to test this, we did a nested case control where we matched atherosclerotic event patients with patients who didn't have an atherosclerotic event on a 3-to-1 match, matched on age and sex. So we took those 2 factors out. We matched for those factors. And look what happens. When you match for those 2 factors, that is, both groups, the event groups and the non-event groups, were matched for age and sex, and you can see they were they were well matched for age and gender, right? All of those other risk factors that we were so confident about disappeared. So all of them were being subsumed by age and gender. And when we then did the time-dependent analysis, one at a time, a univariate analysis, you can see now that none of the factors were significant. And therefore, if none of the factors were significant in the univariate analysis, you know in the stepwise regression multivariate, none would be significant. So in summary, in an inception cohort of 1,400 patients with lupus over a 10-year follow-up, 31 developed atherosclerotic events. The mean time to follow up to an event was 5 years. The univariate analysis revealed that traditional factors present for atherosclerosis within the first year of diagnosis were predictive. But when we did a multivariate analysis, only age and male sex remained significant. And the results were the same even if we removed the effect of age and sex by doing the nested case control as I showed you. So therefore, in conclusion, only age and male gender remain significant risk factors for atherosclerotic events in a multivariate analysis of a multicenter inception cohort followed for a mean of 5 years. The implication here is that these risk factors take more than 8 or 9 years to have their maximum effect. So in the first decade, it's hard to have more than age and sex as a predictive factor, and obviously longer-term follow-up is necessary to identify the importance of the other risk factors. Thank you.
This paper is now open for discussion. So Murray, let me start by asking you, so where are the disease factors? You didn't include them?
We looked at atherosclerotic. We didn't do the disease factors here, as you can see. These are the classic atherosclerotic risk factors.
Okay.